Yeah.
I can see
Okay.
it.
I'm finding you right now. Okay. All right. Cool. So welcome, whoever's listening in, which might not be anybody, or if you're listening to the playback, hello. Tonight is our third topic. So week one, we talked about detox, or month one, we talked about detox. Last month, we talked about just kind of setting the stage for your hormone cycle, your menstrual cycle, just understanding all the different hormones that are important throughout the month and what can happen if there are, obstacles to your fertility. And tonight we're talking about PCOS, polycystic ovarian syndrome, which is one of the most common reasons for fertility obstacles. And so we have two very, very knowledgeable people to help us talk through this tonight. We have Danielle and Louise, and I'm going to let them do their thing, and then I'll come back on the end and wrap up. However, before I do that, and I think we're going to send an email out about this too, but if any of you listening have got your every results back yet, we need to get those from you somehow because they're going to go to you, but not us. So we want to capture that data and combine that with the other data that we've been collecting, so to get like a fuller picture of you. So just if you're listening to this and if you've got your every results back, we need that. And then also, most of you, there's a few people that still haven't finished submitting all of your test kits yet. They're mostly the saliva and stool are the stragglers. So please get those in as soon as possible so that I can prepare your report and chat with you about what we're seeing. So if you need any help with any, if you're running into any logistics problems, please don't hesitate to email me or Jenny with that. So with that, I am, oh, you know what, Danielle, I was supposed to like figure out how to make you do these, be able to do these slides. Shoot. Well,
That's okay.
we'll muddle through. Okay.
Yeah.
So
Do you want me to give you a sign or something?
yeah, like, I don't know.
Okay.
Just just say
Oh,
slide.
okay. We'll do that. Okay. Awesome. Okay. So just in case no one knows, I'm Danielle Cheplowitz. I'm a nurse practitioner and I'm an adult nurse practitioner, but I focus now mainly with women's reproductive health. And so, PCOS, polycystic ovarian syndrome, something that I always stress to women and couples in general is that it's not just a reproductive disorder. It is very complex. It's a syndrome. It's a combination of a hormone disruption and metabolic disturbances. It affects the entire body. The reproductive system is not just in its own little bubble in isolation. As you all know by now, whatever is going on in the body is all encompassing. And so, if we have a metabolic issue within the body, it's going to also disrupt everything else, not just the reproductive system. So, it demands attention. Um, and so this is very prevalent. It impacts about 1 in 10 women, 10%, which is pretty huge. So you definitely know somebody with PCOS for sure. There is also a genetic component. So I do want to stress though that just because you would have potentially have a genetic component, it doesn't necessarily mean you're automatically going to have PCOS. You do need to have an environmental trigger, or usually in most cases it's triggers. It's not just one, but it's the environment and the genetic makeup that triggers the PCOS symptoms. So, and lastly, like one cool tidbit that I had learned years ago is that the theory about PCOS was that it was supposed to be protective. Back in the caveman era, if you had this genetic makeup, you were probably all good because you could withstand famines. You would have more child spacing, less likely to have so many children, which obviously is taxing, especially back in those days. But it's just not helpful for today. So luckily don't have a whole lot of issue with famines these days. And so we don't really need that. But nevertheless, we still have those genetic makeups. So just something to be aware of. So, diagnostic criteria, we'll get into what exactly makes up the PCOS diagnosis. And the Rotterdam criteria is what all practitioners will use. And you must have two out of the three. So you can't just have what looks like cysts on the ovaries and call it PCOS. You need to have two. So these three I will explain. So the first one is irregular or absent cycles altogether. And when I say cycle, I mean menses. There's elevated androgens, and then there's the polycystic appearance on ultrasound, which is the little string of pearls, lots of cysts on the ovaries. So, to kind of break that down a little further, so what is an irregular cycle? You first should probably know what's normal. So, a normal length of cycle is between 21 days and 35 days. And so, if you're having cycles that are more than every 35 days, so the time between one bleed to the next, it's longer than 35 days, that's going to be considered irregular. On the flip side, if you're having a menses, a bleed more often than 21 days, so the time between bleed to bleed is less than 21 days, that's also going to constitute as irregular. And then also in general, if you're having just 8 cycles or less per year, that's also going to be considered irregular. Certainly, if you have absent periods, if you just don't have a bleed, that's obviously grounds for getting this one component of the diagnosis. And then if you just have maybe time where you went like 90 days or longer without a cycle, that's still, going to be considered irregular. For me personally, I like to also have clients just tracked how many days is from bleed to bleed. And so if you're within like a certain number, give or take a few days, is what I would also consider regular. So I would personally kind of say if you're having a 21-day cycle and then a 35-day and then a 21-day and then a 35, that also is irregular, even though it still constitutes within that 21 to 35-day span. Now, elevated androgen, so we mean androgen as testosterone and DHEA. So this could be either clinical signs that you would see on a physical exam, or it would be actual testing values. So maybe the testosterone or DHEAS would be elevated on a blood test. Maybe you don't get blood testing, but you have just frank signs that I will go over on a future slide. But you have signs of high testosterone. That also constitutes as elevated androgens. And then lastly, just to touch over again, the polycystic appearance on an ultrasound. It's the string of pearls is the most common way to describe it. Literally it does look like that on the outside of the ovary, and that's because the hormone stimulation is kind of low. It's just not enough to ovulate a follicle. And so what ends up happening is that a lot of follicles are stimulated, but they never make it to that next level. And so they're just kind of sitting there. And a lot of times ultrasound techs will and radiologists will look at if it's a certain number. So maybe 20 follicles per ovary. Okay, next. So, as promised, the clinical signs. So, acanthosis nigrans, I have a hard time saying that one. It's when you have dark skin in the body folds and creases. So, commonly it would be like under the arms or in the neck folds that you might see this. That's definitely a sign. It could be a sign of insulin resistance and elevated testosterone. Acne, oily skin, alopecia. So a lot of times you will see women that have this certain type of hair loss. It's like kind of like in the front, sometimes in the top. And on the flip side, they might have a lot of hair growth in places they don't want, specifically on the chin. Now, a couple of like little hairs on the chin isn't a huge deal. It's more of like a pretty obvious facial hair growth where you're really in tune with that and you notice that and you're doing something pretty regularly about that. Oligomenorrhea, that again is discussed in the previous slide, means infrequent periods, not regular. Amenorrhea just means no periods. You might see infertility or subfertility. And then, of course, mood disorders is a big one too, that you might see some low mood or anxiousness, and then weight gain, having a diagnosis of overweight or obesity as well. So, what actually causes PCOS? This is my favorite slide because it gets to the why. And a lot of times I don't think this is discussed with patients. So there's three, major ways, especially with functional and integrative medicine, that we kind of look at to see what could be what is the root cause of this. So again, I just want to kind of break down um, the PCOS and state it again that it's a dysfunction of the whole body, and it's a combination of hormonal imbalances plus the metabolic issue as well. So insulin resistance is probably the most common. Most percentage, the highest percentage is in this category. And what is insulin resistance? It's when the body is perceiving that it has enough glucose, and so the insulin levels are rising to meet the demands of trying to shuttle in that glucose into the tissues. And then over time, the tissues become very resistant to it. And so the body ends up just having higher levels of insulin. And so this does a number of things, but you'll see an elevated fasting glucose on the test results. You really want it to be between 70 and 90. Optimal would be 80s. An elevated fasting insulin, you'll see sometimes on LabCorp request test requisitions that it's above 20 something is what they would consider high, but really for fertility and PCOS you want it to be optimal, and optimal is less than 6. I think a lot of literature is kind of pointing towards like 2 to 6, that range. You might see a 2-hour glucose tolerance test where someone is they're eating a certain amount of glucose or sugar, and then 2 hours later they're getting a blood test. And if it's over 140, then that would be considered elevated or having a blood sugar dysregulation. Um, and then we have the HPA axis dysfunction. So, what is that? It's kind of a mouthful, but HPA axis is the hypothalamic, which is in the brain, which then signals the pituitary, which then signals the adrenals, which are on top of the kidneys. The adrenals do make not insulin, cortisol, and DHEA and DHEAS. And so, when we have a lot of stress, we have a lot of cortisol and DHEA being pumped out, the brain will sense that. It's very, very sensitive. And so when the brain is sensing this, FSH and LH, which are in the pituitary, and they're telling the ovaries to stimulate these follicles and grow these follicles, it will basically shut that down or mute it. And so that pulsatile rhythm becomes blunted. And so what you might see is that the follicles are growing a little bit, but they're not growing enough to mature and then ovulate one follicle. And then inflammation. This one I think is very important because inflammation is kind of everywhere. And I think inflammation is kind of the root of all things. But to really kind of like narrow it down for PCOS, you can have inflammation everywhere. That's why we're doing stool testing. Specifically, we're checking certain markers on blood tests to kind of identify inflammation. But inflammation can really trigger PCOS and cause a lot of symptoms in several ways. So, when you're having a lot of inflammation, there's a lot of pro inflammatory cytokines, and those are, again, circulating throughout the body, and it disrupts something called the HPO axis, which is the hypothalamic, pituitary, ovarian axis. And so, similarly to the HPA axis, when we have a lot of cytokines circulating, the brain is sensing this is not the best time to reproduce because there's so much inflammation. And so, again, the FSH and LH levels will kind of drop a bit, at least specifically the FSH, sometimes not as much as the LH. And then the follicles will grow a little bit, but not quite enough to then mature and then release one. Another area is that maybe just in general, the inflammation can trigger the ovaries just itself, and it can lead to poor maturation of the follicles and immature follicles. And then lastly, inflammation can affect how the liver is metabolizing hormones, specifically estrogen. Estrogen is heavily metabolized and processed through the liver. And so this can lead to further hormonal imbalances and then kind of keep pushing that cascade around and around in a circle. So those are the three most important factors. There, could be more, but that's what we're looking at generally. So, how is PCOS affecting fertility? This is what we're all here for. So, um, again, it's disrupting ovulation. And so when you're not ovulating regularly, you have less chances per month, per year to conceive. So the fecundability for each person, like depending on their age, which is the likelihood that you will conceive each month, it's not going to be as high because you're maybe not ovulating as regularly. You're having less than 8 cycles a year. High androgens, so it's interfering, kind of like I said, with the inflammation. It's directly kind of impairing how the follicles are developing. So when we have lots of testosterone and DHEAS, the brain is sensing this. And it's actually sending out a lot of LH and not as much FSH. And so you just get poor follicle development. And then, again, with the regular cycles, it just makes it harder to track when you're ovulating, when to have intercourse. And then with PCOS, you do end up having oftentimes low progesterone, inflammation, and high insulin and glucose levels can directly kind of agitate the corpus luteum, which is what is driving progesterone production in that luteal phase, the second half of the cycle. And so you're not going to have as great of a uterine lining and support for an embryo to implant. So those are the main ones there.
Well, thank you,
Uh,
Danelle, for the segue to glucose, because you were
Sure.
talking about insulin already. For those of you who don't know me yet, my name is Marie Louise. I am a nutritional scientist and dietitian, and I've worked with continuous glucose monitoring and insulin and PCOS over the last 4 or 5 years. So I've seen my fair share of women with PCOS and their glucose levels. But for those of you who don't know, just to tap a little bit into like what actually is insulin resistance. Insulin is the hormone that, as Danielle already mentioned, lowers glucose. And I like to call insulin it's the key that unlocks the cell. So it opens the cell that the glucose actually gets into the cell. And it's whenever we eat or drink something that contains carbs or sugar, our glucose levels go up, and then we need insulin to lower it. And if the cells become insulin resistant, which means like they don't open that well, or like I sometimes like to say it's like the key doesn't really properly open the cells anymore because like the cells are, or that the lock isn't working. The cells become more and more resistant to insulin, but the body is producing more because the glucose isn't going down, right? And so eventually the insulin can no longer keep the glucose levels in check, and the fasting glucose, that's already what Danielle already mentioned as well, is beginning to rise. And unfortunately, by the time many people are diagnosed with diabetes, the insulin resistance has already happened for a lot of years beforehand. That's why it can be super helpful to check insulin level, or that's why it is super helpful to check the insulin levels before. And then maybe you can correct me there, but I think it's like even up to 10 years, you can already tell that you're quote unquote on a path to insulin resistance by checking the insulin levels before, which I think is pretty amazing. Like knowing 10 years in advance what is going on is just incredible.
And and just to interject, I mean, this is not something that your regular PCP normally checks. They don't, I don't know why, but they don't check fasting insulin. And it's even hard to get them to check hemoglobin A1C sometimes.
Interesting.
And like we talked about earlier, that the standards are just different. They're not even going to bat an eye unless someone's hemoglobin A1C is, almost at diabetic level.
Mm.
And just imagine how long that person has been insulin resistant and just missed up to the point. And then everybody freaks out and they say, oh my God, we got to treat you now. You have diabetes. And the opportunity was 10, 15 years ago, when if people just checked fasting glucose, fasting insulin, hemoglobin A1C earlier in the process and caught it and prevent it, that's the whole goal. It's just we wait too late, wait too long.
Yeah, thanks for sharing that. So the problem then also with insulin is that high insulin levels, which we already mentioned, like happen if your glucose levels or if like the body's the cells become insulin resistant, they cause like increased androgen production. They also unfortunately block ovulation, and it can also cause inflammation. And as Danielle already mentioned, like all of those pieces are connected for PCOS, right? So, and I think it's very important to understand, even though we don't necessarily see hormones, right? I think it's like different because we do see blood, or we do see a scar, or we do see like follicles that are different, but we don't necessarily are able to see those hormones. They are all connected and they communicate with each other. And that's why it's very important to understand the connection of like insulin and PCOS, because also like high insulin and insulin resistance, as I said, like it is silent. And as Lynn already mentioned, a lot of doctors don't check that because they don't necessarily produce quote unquote big symptoms. But you may know like, okay, there's like weight gain, especially around like the belt, like quote unquote the belly fat. So a lot of women notice that, okay, something's going on. They don't necessarily have changed anything, but still they're gaining weight. Also like the cravings, which are a result of glucose imbalances, right? Because once you eat something, as I mentioned, if you eat like carbs or sugar, your glucose goes up, and then your body may produce too much insulin because the cells are already insulin resistant. And the logic consequence of our brain or our body is that we need something that gives us energy quickly. And this energy, the quick energy, comes from carbs or sugar, right? And so we eat that and the glucose goes up again, right? And so it's quote unquote this like glucose roller coaster as a result of insulin resistance. And also like a lot of people notice when they don't have a lot of energy, or if their glucose levels are low, they don't have a lot of energy, like they don't feel good, right? They are tired. And some of you may have noticed that even without an insulin resistance, that if you eat like a big portion of pasta, you feel tired afterward, right? And the chances are high that it is because your glucose went up a lot, and then the insulin was released and the glucose crashed. So that's why energy crashes, cravings, or also weight gain can be a sign of insulin resistance. And then there are other like diseases or conditions that PCOS can influence. Let's say like type 2 diabetes. Some of you may see it like as a logical consequence because insulin is so an intricate key component. That's why type 2 diabetes can evolve. Same applies for fatty liver disease, then GERD, which is a type of reflux disease, or also IBS. Also sleep apnea, high blood pressure, heart disease. So there's a bunch of like conditions that may be the consequence of uncontrolled PCOS. And that's why it is so important to understand and address and identify PCOS early, because also the good thing is like if you're able to treat it early, you can work with it and can improve the conditions and can also prevent all of those like diseases that you do not want to have. And then talking about some of the labs that should be checked when talking about PCOS. Danielle already mentioned like the blood sugar markers. We already touched upon fasting glucose and insulin. There's fasting insulin. There's like, as I mentioned, is it even called the HOMA index in the US? Okay, cool. I wasn't sure about that. So that's the index you would want to be checked. Then also the HbA1c, which is the quote unquote long-term glucose. It goes back to like the last 6 months, seeing of like what was the average of your glucose and like how much already of that is connected to insulin resistance, because you want your glucose levels to be, or like the long-term glucose levels to be low, because that also means that your body is pretty good in balancing your glucose levels and the insulin resistance, or like it's a good balance between releasing insulin to lower your glucose levels. And then there are other hormone markers that should be checked when talking about PCOS, as already Danielle mentioned. The testosterone, the DHEA, the diurnal cortisol is super interesting as well to look into. And also very important, the luteal phase progesterone. to confirm the ovulation, because that's how we'd actually know if an ovulation has happened or not. Because if we check like progesterone too early, then we do not know if a woman actually has been ovulating or not, or also other ovulation markers. And then also the estrogen methylation. And I'm not 100% sure, but I think we look like Lyra looks into those as well, right? I think we saw this like super cool graph once, and I have not understand it fully yet, but I think it's really interesting to know that it's out there and that Lyra is checking that too. And then also, thanks to the microbiome, we are able to understand some inflammatory markers. And as Danielle already mentioned, that's why it's important to really do a comprehensive stool analysis, because you can assess what is going on in your gut, and then also the SED rate and the C-reactive protein, because these are also markers to show you if inflammation is going on in your body or not. And then lastly, from my side, there are a few things that you can do. I would say start with the basics, and sure enough, as a nutritionist and dietitian, I'm a strong supporter of like nutrition is key in order to improve PCOS, and obviously also then insulin resistance. Fiber is crucial to, on the one hand, keep your blood sugar stable, but also to really help and support your gut health. Then I also support always the saying of like ditch the added sugars and refined carbs, and go back to what we already see in the visual or the picture on the right. All the foods, the natural foods, they are so beautiful. They have so many colors. They have like so many benefits to our health. That's why really make sure that you eat like whole foods, and really utilize any nutritional habits and healthy habits to also reduce the visceral fat, the belly fat. And even though I believe nutrition is a key to a healthy lifestyle, there are other factors such as like really working on sleep prioritization, really making sleep a priority, getting enough rest, finding your optimal circadian rhythm. That's also why checking the diurnal cortisol levels can be interesting to understand, okay, what is going on in your body. And being fully transparent there, I definitely also need to prioritize my stress reducing practices, and I am sure that many of us do so too. And even 5 minutes a day can already do the trick. And this also supports like your mental health, your emotional well-being. Really put yourself front and center and make sure that you're taking care of yourself. And nonetheless, like strength training, a lot of women are afraid of like working out, really lifting weights, or like only even using their body weight. But having muscles to support the body does support the insulin sensitivity, because it also means we have like active cells that use and need the glucose, right? That's why it's very important to like work out. And again, it doesn't have to be like a full-fledged like gym 45-minute strength training. Just a few minutes a day, going out, doing some gentle movement as well, can really be very helpful there. And then there are some supplements that you could also take to improve your insulin sensitivity. That's inositol and berberine. And then also, to the point that Danielle mentioned, understanding where you are in your cycle and being able to estimate, like if you have a longer or a shorter cycle, use apps or even just use pen and paper to see, okay, what is going on, to track your cycle, to understand where you are at, like if you notice any patterns in your cycle, and also then BPT or LH strips or also mirror help. Really to understand if you're ovulating, where you are in your cycle. And then a last one, support like detoxing pathways, identifying endocrine disruptors and eliminating them, and also making sure that you have a healthy elimination and a happy liver, to get rid of all the toxins in your body, to help your body thrive and reduce the inflammation and everything else that's going on in your body that does not serve you well.
All right, guys, thank you very, very much. That was awesome. So just to kind of wrap up and
That
get
was
some key
really
takeaways.
good, you guys.
Wasn't it though? I mean, I'm so
Yeah,
glad.
really good.
That was like so stellar, top notch. Should sell these things. Okay, so the takeaway that I want you all to leave tonight with is that PCOS is common, but it's also treatable. You know, as Danielle and Louise put so well, the earlier you find it, the better. And there's so much that we can do to help improve it. And as we talk about each week that we meet, also the other takeaway is how all these things are interconnected. You know, we're talking about PCOS, which most people think of as a hormonal issue, but really I think of it as a metabolic issue. It's also an inflammation issue and a gut health issue. So time and time again, we come back to this theme about how the body is complicated and everything is connected. And if you look at just one part in isolation, you're never really going to you're not going to solve the problem as efficiently as if you just take a big holistic view of everything. Blood sugar is so important for everything, but especially when we're talking about anyone with PCOS, it is the key. When we have PCOS patients, we always start with blood sugar, insulin resistance. You'll always find it. I've never not found it. It's just one of the hallmarks that you can bet on is going to be present in someone with PCOS. And of course, we talked about how important the cycle is and that you have influence over that. You know, you can regulate your cycles by fixing that insulin resistance. You can improve ovulation. You can improve egg quality, egg supply by addressing that underlying insulin resistance. So this whole body holistic approach to PCOS is needed without a doubt. And it is something that's treatable. It is something that's reversible. You can absolutely overcome it and it can be in your rearview mirror. And that's always an empowering thing to realize is how much control we do have over these things. So that is it for tonight. Anything that you want to add, Jenny, about, I don't know if you heard in the beginning, I talked about if anybody's gotten their EBI test, please send it our way. You're muted.
Sorry. Brian is like drilling stuff downstairs. So you probably just heard that. I will send out an email to everyone.
Yeah.
Make sure we get that. Yeah.
Okay, cool. Next month topic, I forget off the top of my head. It's either gut health or stress. But stay tuned. We will send out info. It'll be coming your way in mid-June.
I mean, if you want me to look it up, I can find it. But yeah,
No,
I
it's
will.
fine. It's
Okay.
Yeah. Okay. Anything else from you, wonderful ladies, to add?
Thank you
Good.
so much
Good.
to both
Thank
of
you,
you. You
guys.
guys are so smart.
Rock
and
stars.
so knowledgeable.
All right.
Thank you.
Very good. Bye-bye.
Good night,
Bye,
everyone.
thank you.